Hello, today we are going to talk about the use of CT angiography and perfusion in the evaluation and treatment of acute ischemic stroke patients, addressing both standards and potential pitfalls. My name is Edward Sloan. I work with fern.org. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois. I also am Medical Director for New Rose Healthcare Management, helping the emergency department at Roseland Community Hospital in Chicago, a safety net hospital. And I serve as Medical Director for the Physician Assistant Studies program at Dominican University in River Forest, Illinois. This information is being presented at the Clinical Decision Making in Emergency Medicine meeting, June of this year. I want to give my thanks to Joan Esbrey-Cullen, Andy Godwin, Andy Jagoda, Ginia Ports, and Scott Silvers, with whom I've worked at this good meeting for several years. I have no financial conflicts. I serve as the Fern President and Board Chair. This slide includes a link to the social media sites that will allow you to access this information and information regarding other emergency illnesses and injuries in patients with neurological problems. Fern.org is our website. The educational objectives as we discuss the use of CT studies in stroke patients are as follows. We'd like to enhance your understanding of the pathophysiology of acute ischemic stroke. We will allow you to better understand what are CTA and CTP and how these tests are performed. We'd like you to know when CTA and CTP are indicated in the diagnosis and management of acute ischemic stroke patients and how patient outcomes are influenced by this testing. We'd also like to review the AHA-ASA guideline and recommendations made with respect to neuroimaging for acute ischemic stroke patients. We will conclude with the role of NCCT, CTA, CTP, and all neuroimaging for emergency department stroke patients. And we'd like to make it possible to learn based on key clinical questions. An introduction regarding the use of CT studies in stroke patients. Who is the patient population with whom we will be working in the emergency department? First, you'd like to know what types of stroke patients will need these types of testing. And in fact, it is patients with both anterior and posterior circulation ischemic stroke symptoms. Those with anterior stroke symptoms most commonly involve some abnormality or clot in the middle cerebral artery, and those with posterior stroke symptoms will involve some problem with the vertebral basilar system. When we talk about anterior circulation stroke, we're talking about anterior portions of the circle of Willis and blood flow disruption in those areas. You can see on the left there's a large middle cerebral artery seen on CT, and on the right you can see there's an MCA occlusion noted on CT angiography in the yellow circle. When we talk about posterior circulation stroke, we talk about areas that the posterior portion of the circle of Willis supplies and the vertebral basilar system. This includes the thalamus, the occipital lobes, the brainstem, including the midbrain, pons, and medulla, the cerebellum, and other cortical regions in the posterior portion of the brain. So what are our treatment imperatives and standards when utilizing CT testing in stroke patients? So what's our treatment imperative or imperatives? We'd like to rapidly diagnose acute ischemic stroke. We'd like to establish early blood flow restoration to the ischemic penumbra, that area that will benefit from restored circulation. We'd like to minimize the size of the stroke core infarct. We'd like to optimize our 90-day outcome on modified Rankin scale, that is patients with either 0 or 1 who are independent, and we'd like to minimize complications, morbidity, and mortality related to the stroke. So what is our stroke treatment standard? Well, the most commonly understood and well-practiced standard is the use of IV thrombolytic therapy up to 4.5 hours following the stroke onset or ictus. Here is a graphical representation of when the odds of treatment benefit approaches 1, meaning no patient outcome is likely, no benefit is likely to occur with the use of IV thrombolytic therapy. This occurs, the 95% confidence interval around this graph crosses 1 at 270 minutes or 4.5 hours, hence the 4.5 hour therapy marker for IV thrombolytic therapy. What are the key clinical questions and diagnostics that we will use and help us to guide our thinking as we attempt to diagnose and treat stroke patients? First, we'd like to know whether patients in particular can be identified that require acute IV thrombolytic therapy, have an identifiable vascular lesion, have a large vessel occlusion or LVO, should receive endovascular treatment or EVT, and who may benefit from some type of mechanical clot removal or intraarterial thrombolytics. We'd also like to identify patients who are likely to have a complicated hospital course, those who are likely to have a poor long-term outcome and therefore may be best treated without aggressive acute therapies. Now, with regard to stroke patient diagnostics, you ask the question, what tests are we talking about? Well, of course, we need to obtain vital signs, a pulse ox, glucose, a rapid history and physical exam. We'd like to understand when the stroke ictus or onset time occurred. We'd like to do a functional neurological exam. In other words, can the patient walk, talk, see, move their extremities? Are there areas of neglect, or is there aphasia related to some speech abnormality? We'd like to be able to estimate the NIH stroke scale or calculate it if trained in doing so. We will obtain an EKG to make sure there isn't a concomitant acute myocardial infarction. And most importantly, what we'll discuss today is the use of non-contrast CT and CCT and the CT studies listed here. We understand that MRA and other MR perfusion studies are also an option, but we also understand that most often these tests are not used acutely because of the time requirements, especially related to the need for acute thrombolytic therapy. When we talk about CT studies, we are talking about multimodal CT testing and its individual components. So what is multimodal CT testing, and how does it apply? Can I start that slide again? Thank you. What is multimodal CT testing, and how does it apply to acute ischemic stroke patient care? The publication listed here discusses what are the elements of multimodal CT testing. The first is a non-contrast CT. So the first part is to say, on the non-contrast CT, are there findings that preclude the use of IV, TPA, or other thrombolytic therapies? In other words, on the non-contrast CT, are there areas of hemorrhage, edema with shift, mass effect, or tumor? Or is there a large ischemic area that suggests that there is an old stroke present at the time of this evaluation? The aspect score, 1 of 6 to 10, which is good, suggests that there is a small infarct volume and likely improved outcomes after our acute interventions. But bear in mind that the non-contrast CT findings, such as the aspect score and signs such as the individual MCA sign, which is a clot present and visible in the middle cerebral artery, are less relevant than the first items we listed, which are those that would preclude the use of thrombolytic therapies. So in summary, the non-contrast CT is the industry standard first test and first component of multimodal CT testing. In considering these components, the second one from this article listed here by Wanamaker, we consider CT angiography, CTA. So when considering CTA, which is a study of the anatomic structure of the vessels in the brain and surrounding the brain, the first question is, are there extracranial carotid lesions? In other words, are there lesions in the internal carotids that might be a possible source of embolism and or the presence of surgical lesion in the carotids in the neck? Next, we ask on CTA, is there a large vessel occlusion? We know that with large vessel occlusions, patients benefit from endovascular thrombectomy or EV therapies within 6 hours. And with CTA, we can also look at the efficacy or efficiency of collateral flow. In other words, with collateral flow that is adequate, a large core infarct is less likely, and an ischemic penumbra is more likely to benefit from acute therapies. Lastly, the multi-phase CTA helps to identify which is the core lesion or infarct and which is the ischemic penumbra, which is of most benefit or will benefit the most from our acute therapies. So considering our testing components from this multimodal CT and acute stroke article, the last we consider is CT perfusion, CTP. So when considering CTP, this is a test that tracks the flow of contrast as a bolus over time. It allows us to understand what is the size of the core infarct, because the core infarct size at the time of treatment does predict long-term outcome. And the CTP test also allows us to understand whether there is a large ischemic penumbra. A large ischemic penumbra supports aggressive care with IV thrombolysis beyond 4.5 hours, intraarterial thrombolysis, and or possible other endovascular treatments up to 24 hours after stroke ictus, especially with posterior stroke problems. So what about multimodal CT as a diagnostic modality? There are 2 articles listed here that address this question about the multimodal CT testing approach. And why is this considered to be an optimal treatment or diagnostic step in our treatment paradigm for patients with stroke? Because with these tests, we can make treatment decisions based on vessel occlusion, the presence of collateral blood flow, and the tissue characteristics, both the size and extent of the core infarct and the ischemic penumbra. And this may better predict outcomes after reperfusion therapy than simply assessing how long it has been since the apparent stroke onset or ictus. This allows us to say that our acute ischemic stroke patient treatment is no longer just a time-dependent problem. It avoids the issue of not knowing for certain when the stroke ictus occurred, and it allows for better decision-making with patients with low NIH stroke scale severity strokes. Most importantly, it does allow the stroke patient care to be individualized to the characteristics of that patient's brain with regard to collaterals, the size of the core infarct, and the size of the ischemic penumbra, which may benefit from our acute aggressive therapies. Let's talk a minute about the core infarct and the ischemic penumbra. What's the difference between the core infarct and the ischemic penumbra? We know that both areas have poor flow through some target vessel when an acute ischemic stroke occurs. The core infarct has bad cerebral blood flow and a bad cerebral blood volume. This means that with poor flow and poor volume of blood, there is limited oxygen delivery via hemoglobin, there is non-salvageable tissue, and the changes in this area over time become irreversible, and this core infarct is permanent. The ischemic penumbra, which is different, has cerebral blood flow and cerebral blood volume which is almost adequate for maintaining tissue integrity and avoiding infarction. In fact, there's just enough cerebral blood flow and cerebral blood volume that with optimal care, early restoration of blood flow through the target lesion, tissue viability can be maintained and the ischemic penumbra will not then become dead core infarct. And so the main question is, how is it that we can restore tissue oxygenation to this ischemic penumbra so that with good care, the ischemic penumbra becomes viable again and long-term effects are minimized, versus a situation where we are unable to restore adequate blood flow and this ischemic penumbra becomes more infarct tissue, which will impact both morbidity and mortality long-term. So how is the size of these two tissue states, core infarct and ischemic penumbra, how are they related? You can see here in this graphical representation, the core infarct is in black. On the left, a small infarct and a large ischemic penumbra at 30 minutes. And you see at 2 hours, the core grows. And at 12 hours, all of that ischemic penumbra tissue has now become established infarct, and long-term effects will be manifested because of the large volume of the core infarct. If, on the other hand, it is possible to avoid changing that ischemic penumbra into core infarct, and if it is possible to minimize the size of the core infarct, the long-term complications are minimized and the patient has a better outcome when looking at modified Rankin scale at 90 days. It's now important to consider large vessel occlusion, or LVO, when considering CT multimodal testing in acute ischemic stroke patients. Why is the presence of a large vessel occlusion important to detect in acute ischemic stroke patients? Large vessel occlusions, LVOs, cause approximately 1/3 of acute ischemic strokes. Yet, these LVOs are responsible for 90% of the mortality related to this condition and the severe neurological disability in acute ischemic stroke survivors. In other words, the LVOs are the lesions that are most important for causing morbidity and mortality in patients who present to the emergency department with acute ischemic stroke. And we know that endovascular thrombectomy and other therapies decrease disability, improve functional outcomes, and decrease mortality over standard therapies, especially in patients with anterior circulation large vessel occlusion. And so why is it important to detect these LVOs? Large vessel occlusions often will cause a large volume of at-risk ischemic penumbra, which requires acute therapy. There's a greater likelihood for a rapid infarct to grow, or to grow rapidly, in this at-risk tissue, especially with the presence of an LVO. We know that there's a limited therapeutic window for endovascular therapy with LVOs because the decreased blood flow and oxygenation is so severe with LVOs that there is a limited amount of time for preventing the ischemic penumbra from becoming a core or growing core infarct. And with patients with LVOs, we need to consider transfer to a comprehensive stroke center with these patients, because in centers that do not have the ability to go to the IR suite and provide endovascular therapies, it is necessary to rapidly get these patients transferred and to coordinate the planned EVT therapies, especially for patients with large vessel occlusions. So in summary, LVOs cause the enhanced patient risk and the need for optimized treatment decision making, which could include transfer of patients to a comprehensive stroke center. Now, what is meant by the VAN assessment for possible large vessel occlusion? This article demonstrates that it is possible to estimate whether there is a large vessel occlusion without specific CT multimodal testing. When we talk about VAN, we're talking about vision, aphasia, and neglect. And these are functional neurovascular anatomy deficits. These are cortical abnormalities that suggest a large vessel occlusion. And in fact, they are likely to provide some clinical utility as compared to simply saying large strokes are more likely large vessel occlusions, and by large strokes we mean NIH stroke scales greater than 5. So let's talk about this a little bit more. How do we compare the VAN assessment versus the NIH stroke scale greater than 5 for detecting a large vessel occlusion? Both of these tests are 100% sensitive with 100% negative predictive value. That is to say, if you do a VAN assessment and there's no visual, aphasia, or neglect abnormality, or the NIH stroke scale is 5 or less, it is highly likely that there is no large vessel occlusion, and in fact, it's more likely a lacunar infarct. We do know from this study that the VAN assessment is more specific, 90 versus 74% versus NIH stroke scale greater than 5. And the VAN in this sample size, or this group that had a 23% LVO rate from this study, that the positive predictive value is higher with the VAN assessment versus simply an NIH stroke scale greater than 5, 74 versus 58%. In other words, VAN assessment had fewer LVO false positives versus this NIH stroke scale greater than 5 cutoff. And it does suggest that if you simply do a neuroanatomical clinical exam, that VAN can detect the presence of an LVO without over-predicting the likely presence of an LVO. So, in summary, what does this VAN assessment mean? In patients in whom you detect extremity weakness, you then look for these 3 VAN cortical findings. If one of them is present, it suggests that there is a likely large vessel occlusion. So the VAN assessment, which can be done without any neuroimaging, facilitates LVO detection. It allows for the treatment of LVO by rapid thrombolysis and the transfer for EVT. If the VAN is negative, then LVO is much less likely, so that other neurological etiologies for the symptoms may be detected not with CT multimodal studies, but with MR testing. In other words, if the VAN assessment is negative, perhaps there's a less urgent need for CTA or CTP if it's not immediately available. And if the VAN is positive, there's a good chance that an LVO is present in a clinically relevant population of patients who are at risk, and we know that this was a 75% positive predictive value in this small study that had a 25% LVO rate. So we're now going to talk about the elements of the multimodal CT testing paradigm or diagnostic approach in patients with acute ischemic stroke. Let's start with CT angiography, CTA. What are the study technicals of this test? What is the CTA study and what does it demonstrate? It provides a contrast view of both extracranial neck and posterior circulation and intracranial vessels. It goes from the aortic arch to the cranial vertex, and it provides here a superior spatial view of the cerebral vessels. How is a CTA done, and what are the time and technical requirements for performing a CTA? 50 to 75 cc's of IV contrast are provided. It is performed within seconds of the contrast injection. There is some post-processing formatting required, but there's no significant time or technical requirements for this testing. And importantly, prior serum creatinine is a consideration for those who are at risk for severe renal disease or renal failure, but most often in most patients it is not necessary. What are the indications for CT angiography? When is a CTA study indicated in acute ischemic stroke patients? Theoretically, all patients should get a non-contrast CT and a CTA. Why? The CTA identifies clots, collaterals, and vascular variants. It can be done rapidly, it is relatively low risk, and it's technically feasible simply with the injection of the contrast. However, it is not mandated in all patients, and we'll talk more about this at the end of our lecture today. If we assume that only about 20 to 25% of acute ischemic stroke patients have a large vessel occlusion, then the acute diagnostic paradigm and treatment approach does not always mandate this testing. And because an LVO is more likely with an NIH stroke scale above 7 to 9, LVO is not as likely to be diagnosed via CTA in patients with a lower NIH stroke scale, although it does occur on some occasions. The point is, because there are not LVOs in all patients who present with stroke, it is not necessary that this test be done in all patients, even though it is preferred that this treatment or this diagnostic test be utilized. Also, we know that in low NIH stroke scale or mild strokes, that an LVO isn't always present. In fact, most often it's not present, such that it is not always necessary to have a CTA performed in these patients. The reason I bring this up is because if you're in a center that treats patients but you do not have the ability to perform CTA, that it may still be possible to optimally treat patients with acute ischemic stroke, especially when LVOs are not likely, as in patients with low severity stroke. What about positive imaging and patient treatments in patients with CT angiograms? You see here on the left, you see a cutoff in the middle cerebral artery in the yellow circle related to a thrombus or embolus that is present in this. So this MCA large vessel occlusion in fact shows you on the right in the area with the yellow arrows the presence of the clot within the MCA itself, called the MCA sign. This is apparent on non-contrast CT and does not require a CT angiogram to observe this. So how does a positive CTA study change and improve AIS patient care? Well, if you can do a CTA, it may detect a large vessel occlusion in lower NIH stroke scale score patients who have mild stroke symptoms. And for sure, it will identify LVOs, especially in the more at-risk group that has more severe stroke with an NIH stroke scale greater than 7 to 9. It surely prompts mechanical thrombectomy and other EV therapies to be considered. We know that only approximately 7% of acute ischemic stroke patients may receive some mechanical thrombectomy for LVO patients in practice. And this suggests, again, that if you aren't able to detect it with a CTA, you still should be able to optimally care for these stroke patients. But what is most important is the ability to determine with a CTA that there is a thrombus or embolus in a large vessel. It may cause more of these AIS LVO patients to be treated aggressively for the LVO using EVT. What about stroke patient outcomes and care standards with regard to CT angiography? Has the use of CTA changed outcome in AIS patients, and which patients? In this study, we demonstrate that when patients present within 6 hours, a protocol with CTA for all patients, this study suggests improved stroke progression, fewer complications, and improved outcomes in LVO patients. So is CTA use the standard of care, and in which patients? In summary, in centers where non-contrast CT and CTA can be rapidly performed serially with the patient on the CT table, this approach clearly is optimal. The baseline creatinine may not be universally required. In fact, without significant renal risk, it probably should not be determined before the CT can be done and the CTA. With the non-contrast CT and CTA, the ability to identify an LVO and to transfer patients for EVT is often easily achieved because of the ability of these two tests done serially. But remember, CTA use, however, is not required to provide thrombolytic therapy up to 4.5 hours in acute ischemic stroke patients. Next, when considering multimodal CT testing, we need to consider the use of CT perfusion or CTP. What are the components of CT perfusion? What is this study? How is it performed? What does it demonstrate? The CT perfusion study does contrast sampling every 2 seconds for 60 seconds. It provides a 4-dimensional data set with 3 dimensions, 3 directions, and a time component. It provides perfusion maps which represent hemodynamic properties of the tissue at risk. Using a devolution algorithm, it provides computed perfusion parameters. So what are the 3 parts of the CTP study? You see on the left there's a non-contrast study. Then there are studies that include cerebral blood flow, CBF, cerebral blood volume, CBV, and then characteristics that talk about the rate at which blood flows through this area, both a time to peak and a mean transit time for this blood and contrast to move through the at-risk tissues. What's the purpose of these 3 components? It's to answer the question, is there an ischemic penumbra that can be salvaged by returning perfusion to the area by dissolving or removing the clot in an important vessel? Let's talk about these components. The first is cerebral blood volume, CBV. With CBV, you ask the question, how much of the brain volume is blood? And the question is, what's the volume fraction of tissue that is actually vascularized and includes blood? And typically the CBV is 2 to 5%. And when considering a cutoff that would suggest a core infarct, we're really looking at comparisons in CBV from the affected side as compared to the normal side. What about cerebral blood flow? You ask the question, how much blood flows through the brain over time? And the question is, what is the blood flow amount per minute per 100 mils of tissue? Typically, cerebral blood flow is normalized or compared to a presumed normal reference region of the brain on the other side. And so CBF, or cerebral blood flow, is expressed as a percentage. So if the CBF is 30%, for example, in an infarct-related region, then it is 70% less than in areas with normal blood flow. And a cerebral blood flow at less than 30% of normal does reliably suggest a core infarct tissue area. You see on this scan, the heavy blue area would suggest a large core infarct because cerebral blood flow is dramatically diminished related to the presence of the clot in a cerebrovascular area. What about mean transit time? Mean transit time talks about how fast is blood flowing through the brain tissue. In other words, what is the average time for flow from the arterioles to the venules through the tissue? This is your wash-in to wash-out time for the contrast. Last is time to peak. This talks about how quickly is blood flow maximized through the tissue that is at risk. And if you say, what is the time to peak flow into the arterial system so that oxygen can be carried to the at-risk tissue? And a time to peak of greater than 6 seconds suggests ischemic penumbral tissue, which is at risk and which will benefit from the activities that resolve the clot and restore blood flow. Again, let's talk about the core infarct and the ischemic penumbra with regard to CT perfusion. What's the difference between the core infarct and the ischemic penumbra? The time to peak and the mean transit time, in other words, the rate at which blood flows through this at-risk tissue, is prolonged in both the core infarct and the ischemic penumbra. The difference is the core infarct has very low cerebral blood flow and very low cerebral blood volume. In other words, with these both being low and a long time to perfusion and occlusion that's present, there's no oxygen being deliverable, and this is non-salvageable tissue. In other words, when there's a low flow state and there's low blood volume in the area, it is likely now a core infarct. The difference with the ischemic penumbra is that the cerebral blood flow and the cerebral blood volume are partially maintained, often due to collaterals. And even though there is a long time to perfusion and the mismatch with the presence of adequate or nearly adequate blood flow and blood volume suggests that this ischemic penumbra may benefit if you can resolve the clot. In other words, this mismatch in the ischemic penumbra may be related in part to the clot, but also in part due to vasodilatation and too slow flow in the ischemic penumbra, and not necessarily just from the clot itself. Hence, the possible viability of the ischemic penumbra. Courtesy of Chris Lewandowski, here's some pictures that demonstrate the difference between the core infarct and the ischemic penumbra. With the core infarct, the mean transit time and the time to peak are both increased, but this is true of both the infarct and the penumbra. But in the core infarct, you can see here on the right, cerebral blood flow in blue is much diminished, and cerebral blood volume is much diminished. These are characteristics of the core infarct. The ischemic penumbra, which also has mean transit time and time to peak, which are delayed or increased, you can see here with the red on the left-sided images. The cerebral blood flow and cerebral blood volume on the right actually are almost adequately or optimally maintained, suggesting that this is ischemic penumbra because there is currently adequate blood flow and blood volume. It is just not optimized, and it needs to be optimized in the ischemic penumbra through some thrombolytic therapy or endovascular therapy. So, the CT perfusion question is, how can cerebral blood volume and cerebral blood flow approach normal in the ischemic penumbra if there's a vascular lesion and mean transit time and time to perfusion are diminished? And the question is, how does oxygenated blood being delivered to the stroke ischemic penumbra tissue? The answer is, it is likely related to collaterals which influence these hemodynamic parameters, and as we stated, cerebral blood volume and cerebral blood flow relate not only to the flow in the occluded vessel of interest, but also due to collateral flow and the characteristics of those collateral vessels, which may be dilated and hence cause there to be a diminished time to peak or mean transit time. What are the study technicals for the CT perfusion study? And what are the time and technical requirements for performing a CTP study? The CTP does require 50 cc's of IV contrast. This would be in addition to the CTA. And it requires many views to be obtained in the same area over time, so you have the fourth dimension of the CTP. It is performed within seconds of contrast injection. It requires significant post-processing reformatting to be done. The time related to this post-processing testing may be relevant. That is, it might be long enough that there would be a delay in a CTP, even if the CTA results are present. It does require some comparisons between packages that do this testing for the radiologist and the tech. And the interpretation by the radiologist does require some expertise and may optimally be done by a neuroradiologist. So, regarding the software that allows this CTP to be technically determined, what are the issues regarding these softwares? There are multiple products. The perfusing processing is a non-standard domain, which means that different packages do the testing or calculations in a different way. There are substantial differences between packages. You can't compare one package to another easily. And so it is important that whatever package is utilized becomes an area of expertise for the neuroradiologist. What are the CTP indications? When is a CTP study indicated in acute ischemic stroke patients? Well, when standard therapies are not indicated, that is, when the stroke ictus occurs more than 4.5 to 6 hours before the time the patient is evaluated, you might consider a CTP to understand whether or not other therapies might be utilized. So, in patients with a long time from ictus to evaluation, and in patients with posterior circulation strokes, where there are some therapies that might be of benefit after 6 hours, a CTP should be considered. Outside of the IV thrombolytic therapy window, a low or changing NIH stroke scale, in other words, a low severity stroke, when there's an uncertain ictus, as within wake-up strokes, when there's no apparent large vessel occlusion on CTA, CTP might be of benefit for demonstrating the presence of a large ischemic penumbra. Or when there's a severe deficit, especially with posterior stroke, and when utilizing research protocols that study the predictive value of CT perfusion. Now, what does a positive image look like, and what about patient treatment as a result of these positive images? What does a positive CTP study look like? This is the reference that gives you these images we're about to discuss. So this is the overview of what you see with the CT perfusion. The non-contrast CT, in yellow circle, is read as normal, no lesions. The CT angiogram shows a cutoff because of a thrombus in the MCA M1 segment. The time to perfusion is delayed in this MCA region, but it does spare the basal ganglia, which is next to it in green. Now you can see there is reduced cerebral blood flow in the same area as the area that had the increased time to perfusion. In other words, there's more blue on this side as compared to the right. And lastly, the relative cerebral blood volume in this MCA area is near normal. In other words, the two sides on this last image where there's a yellow circle appear similar. And as we stated, if the relative cerebral blood volume approaches normal, this could represent an ischemic penumbra and not a fully established core infarct. So, what was this case study? A 77-year-old patient with hemiparesis, aphasia, and a wake-up stroke. Remember, the aphasia suggests a VAN-positive patient, which in the right at-risk group might suggest a 75% likelihood of an LVO. The non-contrast CT was normal with just some chronic brain changes. The CTA showed an MCA M1 segment occlusion. The time to perfusion was prolonged, consistent with some vessel occlusion, but it could either be infarct or penumbra. The cerebral blood flow is relatively impaired compared to the normal size. However, the cerebral blood volume is near normal, suggesting an ischemic penumbra. So the question then becomes, should some treatment be provided in this wake-up stroke patient in whom we don't know the exact time of the stroke ictus? And the answer with a large ischemic penumbra is yes. EVT and other therapies may be of benefit to this patient because the core infarct is relatively small and the ischemic penumbra is relatively large. In this next positive CT perfusion study, we will consider the issue of a potential large core infarct. You can see in the images that contain yellow circles on the left that there's a large area of markedly diminished cerebral blood flow, cerebral blood volume, and a prolonged TTP and MTT, suggesting a large core infarct. At 24 hours, however, on the right with a non-contrast CT, the yellow circle demonstrates that there was a smaller core infarct than the CT predicted at the time of the baseline evaluation. And this is one of the potential pitfalls of using CTP, is that it may overcalculate what area will end up having a core infarct or stroke at 24 hours and at times beyond. So what about CTPs that are positive and our treatment therapies? How does a positive CTP study change our AIS patient care? Well, it does allow us to provide IV thrombolytic therapy beyond 4.5 hours when indicated, that is when there's a large ischemic penumbra and small core infarct. It does allow interventional techniques including intra-arterial thrombolytic therapy and mechanical thrombectomy to be provided. And it allows us to understand the possibility of endovascular therapy up to 24 hours after the ictus. So, when there is a positive CTP that suggests a large ischemic penumbra, you can then do an interventional consult for possible treatment, possible transfer to a comprehensive stroke center, and participation in ongoing clinical trials, especially if there's a posterior stroke, which can have devastating outcome if no therapy can be provided. So what about acute ischemic patient outcomes and care standards related to CT perfusion? Has the use of CTP changed outcome in acute ischemic stroke patients? And if so, which patients? The Extend-IA and the SWIFT Prime studies both use CTP to screen for a large ischemic penumbra prior to using the intervention EVT. This CTP used as a selection criteria led to a 60% and 71% favorable EVT outcome in these two studies, which are the two highest recorded from these two 2015 studies. We do understand, however, and this again is a potential problem, that if you use CTP to determine which patients will receive EVT, it is possible that some patients get excluded even though they might benefit from this EVT therapy. More on that later. What about the use of CTP? Is it universal? Is it reliable? Well, one study looked at 50,000 patients from 2021, and it showed that CTP was only used in 3% of patients. So if you are in a center that is unable to use CTP because it's not available, you are not alone and you are not an outlier with regard to your ability to appropriately and optimally treat ischemic stroke patients. And there was a quote from a study that said the use of CTP predicted the ischemic or infarcted core area and the ischemic penumbra regions in a way that could be a little bit inaccurate or unpredictable. So from this, we know two things: that there's an opportunity to grow the use of CTP for more patients with acute ischemic stroke, and we know that with time, and now at 2023, we probably know more with regard to having some better common understanding of how decision making can be optimized within the framework of CTP use real time. Now, what prompts this study to be considered a standard of care? In the yellow circle, a standard of care study is developed when it's available for use and used broadly, when it's cost effective, when it has high accuracy and high reproducibility, and its use is agreed upon and understood by a large swath of providers. So, is the use of CTP standard of care in acute ischemic stroke patients? We do know that CTP more consistently is able to predict disease, especially the presence of a large ischemic penumbra, with the use of artificial intelligence. We know that CTP results may vary across different AI software packages. And we know that CTP and its AI calculation component are not likely used as broadly as our NCCT and CTA, the other two parts of our multimodal CT approach. We know that CTP is most often used in comprehensive stroke centers and systems. And we do know that if you can utilize a non-contrast CT, CTA, and CT perfusion, this in fact may be the most cost-effective way, even though these tests have a cost themselves. It still might be the most cost-effective approach to managing patients with suspected or confirmed acute ischemic stroke. And we know there are qualifiers in the literature that suggest more is to be learned prior to standardizing the use of these common AI decision-making tools so that we can generalize to all centers caring for acute ischemic stroke patients. Now, what about this artificial intelligence and its clinical use in patients with a suspected acute ischemic stroke who require a CTP? So, does this software allow for core infarct and ischemic penumbra detection? Surely. Remember, though, that the neurological exam and a functional neurological exam grossly detect both the area of the core infarct and ischemic penumbra, remembering that if there is weakness and a positive VAN assessment, vision, aphasia, or neglect, that it's likely an LVO. Despite the fact that clinically we can detect that, the AI software does assist us in detecting the presence of an LVO and the resultant large ischemic penumbra, which would prompt us to go on to more aggressive therapies even beyond the 4.5 to 6 hours following the stroke ictus. We do know that AI can distinguish the infarct from penumbra, which of course is useful. We know that mean transit times greater than 6 are seen in both the core infarct and ischemic penumbra regions. So from this, we know that mean transit time greater than 6 detects the total ischemic area, both the infarct and penumbra. And if we can find the area where the cerebral blood flow is less than 30% normal, and that detects the core infarct, we can then distinguish which is infarct from penumbra in the total ischemic area, because the core infarct is a part of the larger area that includes both core infarct and ischemic penumbra. So let's talk about this. The total affected area is both the ischemic penumbra and the core infarct. The ischemic penumbra then is the total area of ischemia minus the area which is the core infarct, like doing a DWI study with an MR. So the penumbra and the core infarct both have mean transit time greater than 6. However, the core infarct has a cerebral blood flow less than 30% in the region. And so the ischemic penumbra here is in green and the core infarct is in red. So the core infarct is the smaller red area. In this case, the larger green area suggests there is still ischemic penumbra, which may benefit from aggressive therapy. So what about these different types of artificial intelligence? One is called Rapid AI. Here are screenshots from their website. It's been done over 2 million times in over 100 countries, 14 clinical trials, 1,800 hospitals, so there is extensive clinical experience. And it does allow for different types of reading technologies to be utilized. The aspect score, CTA, the detection of LVO, CTP, and it can be correlated to MRI testing. So, does it allow for core infarct and ischemic penumbra detection? The answer is yes. In this study, you can see the areas of red that demonstrate a small core infarct, and the areas of green which are a large ischemic penumbra, which when compared to MR demonstrates something very similar. The point here is you can distinguish with this type of artificial intelligence what is the core infarct from the ischemic penumbra, knowing that those with a small core infarct and a large ischemic penumbra may benefit from more aggressive therapy, even beyond the 4.5-hour cutoff for IV thrombolytic therapy. So the core infarct and ischemic penumbra, here's the favorable clinical scenario. If there's a large independent ischemic penumbra in green and a small core infarct in pink or red, then we know there are two non-matching tissue territories, and the one area that is large, the large green ischemic penumbra, will benefit from aggressive therapy, including EVT. The less favorable clinical scenario is simply a large core infarct in pink and a small independent ischemic penumbra in green. And so when the ischemic area includes mostly infarct and these matched areas suggest limited benefit from more aggressive therapy, it's less likely that the use of EVT when there's a large infarct and a small ischemic penumbra is going to improve outcome at 90 days and beyond. So let's take a look at this. If you look at this large ischemic penumbra, small core infarct demonstration, the cerebral blood flow less than 30% is only 50 mLs, and the mismatch volume or the ischemic penumbra is 365 ml. We know that there is a large ischemic penumbra and that aggressive EVT therapies should be utilized. The different demonstration of the less beneficial situation is where there's a large core infarct. In this situation, cerebral blood flow less than 30% is 241 mLs, and the mismatch volume or the volume of ischemic penumbra is only 57 mLs. So you could see if the ischemic penumbra is 1/5 the size of the core infarct, it's not likely that aggressive therapies will provide much benefit at 3 months and beyond, such that it may be considered that in this patient, aggressive EVT and transfer to a comprehensive stroke center may be of less benefit. Let's talk about a different artificial intelligence called Viz. And Viz utilizes some system integration of its software, and it allows workflow to be conducted so that the CTA and CTP are efficiently performed and interpreted, and the results end up in the hands of the provider rapidly. And so how effective is this software? In fact, for detecting LVOs, this software is 96% sensitive and 94% specific. And we know that any test that has a 95% sensitivity and specificity is highly accurate. And this allows us to detect with this software the presence of LVO. Now, please note these in this example, the prevalence of LVO was 6%. Or 1 out of every 16 stroke patients, and this is less than the prevalence that was seen in the other study, which had a 23% prevalence of LVO. The point here is LVOs may not be as common as you might think in stroke patients, but when they do occur, you ought to be able to determine them using a simple non-contrast CT and a VAN assessment, and you should be able to aggressively treat them if their NIH stroke scale is over the higher 7 to 9 range. Let's talk about some Let's talk about some special considerations in AIS neuroimaging. The first, of course, is MR imaging and perfusion studies. So what is the role of MR imaging and perfusion studies for acute ischemic stroke patients? Remember, MR does detect hemorrhage and stroke etiologies quite well. And MRA has a similar utility to CTA, but often is used more subacutely, that is not at the time when a consideration is made for the use of thrombolytic therapies or EVT. We know that MRA can be done without gadolinium contrast. We know that MR DWI does detect hyperacute ischemia with good sensitivity, specificity, and accuracy. And we know that it is possible with the use of DWI and FLAIR studies to identify patients who would benefit from EVT. We also know from the Diffuse 3 study that the diffusion-perfusion mismatch on MR does successfully select patients for the extended window for reperfusion therapies. And we know that MRVs are useful when venous occlusion is suspected. So, MR neuroimaging and the ischemic penumbra images. What does an ischemic penumbra or a PWI-DWI mismatch look like? This happens to be a 40-year-old female, left-sided weakness, NIH stroke scale, which is quite high, suggesting a likely LVO. In fact, was due to a right internal carotid occlusion. And you could see what's important here is the yellow ischemic penumbra identified on MR. This is another example where the penumbra is identified in yellow. A 31-year-old male, sudden left-sided weakness, NIH stroke scale high again of 16, a right internal carotid occlusion. And so you can see in these two patients who had carotid occlusions as a cause of their stroke, with MR, you can identify an ischemic penumbra as identified here in yellow. And you'd say, well, what was identified at the time that they did a non-contrast CT, a CTA or CT perfusion? Remember, in patients in whom the likely scenario of a middle cerebral artery being occluded due to some thrombus or embolus, you might use the MR as an alternate therapy or diagnostic for determining the cause of the stroke in patients that are not typical, those who are young, for example, as compared to older patients. So what about neuroimaging in young acute ischemic stroke patients? How does stroke evaluation differ in young AIS patients? Well, in younger patients, you need a heart-to-head evaluation. You need to go all the way from the brain to the neck to the heart to determine a possible etiology for stroke, because stroke is not common and is not often related to an abnormality in the cranial cerebral vascular vessels. So you need a non-contrast CT and a CT of the head and neck. An MR-DWI will show an apparent diffusion coefficient, and the FLAIR study will assist in determining what the likely stroke ictus onset time was. An EKG is required for young stroke patients, as well as a heart echocardiogram using a TTE and a bubble study for identifying any areas where there's flow between chambers that is abnormal. You need a lab assessment of lipid disorders and atherosclerosis. You need to look at multiple vascular territories, not just the head and neck, because this stroke in a young person may be related to some type of vasculitis or embolic phenomena. And we need to consider fibromuscular dysplasia, or FMD, which is a non-inflammatory cause of vessel abnormality. Now, once you determine the cause of the stroke, strokes in young patients have similar patient management as those who are older and diagnosed through more standard tests, NCCT, CTA, and CTP. So what about this FLAIR study? A FLAIR is a fluid attenuated inversion recovered study. It's an advanced magnetic resonance imaging sequence that reveals tissue T2 prolongation with cerebrospinal fluid suppression, allowing the detection of superficial brain lesions, such as those cortical lesions that might be detected with the VAN assessment. So it's a useful tool in the diagnosis of acute ischemic stroke because it can help to estimate the onset of the acute ischemic stroke within 6 hours, which may enable more patients to receive thrombolytic therapy. So the MRI FLAIR is good at detecting the core infarct at less than 6 hours. And when the FLAIR is negative, but a perfusion defect is noted, then the stroke ictus is likely to occur greater than 6 hours, but still within the time frame where EVT, aggressive therapies, may be useful. In other words, if the FLAIR is negative and there's no demonstration of a core infarct, but an ischemic penumbra is identified, it is then possible to then refer these patients for more aggressive EVT therapies between 6 and 24 hours. What about neuroimaging cost? We made a mention of this, but let's consider it. Are the cost considerations of different neuroimaging strategies important to us as we consider both the acute costs and the long-term costs in patients who are disabled from stroke? So a comprehensive CT approach does create the most value. That is, the NCCT, CTA, CTP is more cost effective than waiting and utilizing MR therapies. CTP testing is especially useful up to 6 hours following the ictus, and the radiation risk is especially low in patients who are less than 70 years young. And we know with the neuroimaging that we've demonstrated here and the multimodal CT, you can establish efficient workflows at comprehensive stroke centers that give you the best cost bang for your buck. Now, what about endovascular therapy? So what's the status of endovascular therapies in acute ischemic stroke patients? So endovascular therapies are really in search of the optimal way to treat large vessel occlusions and large ischemic penumbras when there is a small core infarct. We know that perfusion studies help in suggesting when EVT might be therapeutic, especially beyond the 6-hour window. We know EVT may be useful in part with the use of intra-arterial thrombolytic therapies. We know that there are second-generation devices, mechanical devices that exist that allow the clot to be removed successfully. We know in patients with an aspect score less than 6 and an infarct size greater than 70 mLs, these patients may especially benefit from endovascular therapy, especially because they define a larger patient group. We know that EVT beyond 24 hours may be beneficial in treating the ischemic penumbra, especially when considering posterior stroke. And we know that the use of endovascular therapy in mild stroke patients, those with an NIH stroke scale less than 6, may benefit from EVT. So in summary, EVT is available for treating patients who are of benefit because they have a large ischemic penumbra, especially those who are beyond the IV thrombolytic therapy window, in patients who may benefit from intra-arterial thrombolytic therapy, in patients who may benefit from clot removal using second-generation devices, in those who are defined as having the best likely outcome with aspects and infarct size score, and in those in whom treatment beyond 24 hours it may be of benefit with EVT, including those with small or mild strokes. So what are the AHA and ASA recommendations? I've pointed out from the recommendations themselves where the specific guidelines are mentioned. So in these following slides where the arrows exist, I will just quickly move through the questions and show you where they are demonstrated in the AHA, ASA neuroimaging guidelines here. You can see that many questions have good or type 1 recommendations and others have 2 recommendations which are supported less strongly by the literature. But let's go to our conclusions so that you understand best what these recommendations tell us. What about the use of non-contrast CT, IV, alteplase, or other thrombolytic therapies, perfusion studies, and in those with unknown ictus time? What do the recommendations say? The recommendations state that non-contrast CT and MR both exclude intracerebral hemorrhage prior to thrombolysis, so you don't have to do MR studying. The recommendations state give IV alteplase or other thrombolytic therapies prior to MRI or the exclusion of microbleeds on MR. Don't delay IV alteplase to obtain perfusion studies if you don't have those in your center. And CTA and CTP or MRA DWR are useful in certain patients. Which are those? Those especially with wake-up stroke, unknown ictus time, or when EVT is an option beyond the IV thrombolytic therapy 4.5 hour window. So, if there's a wake-up stroke or unknown ictus time, you can use MR to find DWI or flare noted patients for IV alteplase within 4.5 hours, or stroke identification of a large ischemic penumbra and a small core infarct beyond those 4.5 hours. What about these other areas? LVO, ETV criteria, vessel imaging, and perfusion studies. The guidelines say if the ETV criteria are met, then you can use CTA or MRA to image the CNS vessels. Or if a LVO is suspected, you can do the same. The guidelines state if there's no renal history, there's no need for a prior creatinine. If an ETV therapy is in play, you should image your extracranial carotids and vertebrals. And you should image the collaterals when considering mechanical endovascular therapies, including thrombus removal. And when you have an anterior LVO between 6 and 24 hours, you can use CTP or DW-MRI to verify the eligibility for EVT based on prior EVT clinical trial results. What about early stroke, LVO, anatomical lesion identification, or EVT itself? So what do the guidelines say about AIS neuroimaging in these situations where you're trying to identify the anatomical lesion? The guidelines say in stroke patients less than 6 hours, where the aspect score is 6 or greater with a suspected LVO, you should do vessel imaging with CTA or MRA to guide your use of endovascular therapies and referral to a comprehensive stroke center, as opposed to waiting and doing additional perfusion studies to add to your decision making. In other words, less than 6 hours in patients who may optimally be treated with EVT in order to rapidly allow for evaluation for EVT and transfer. Do the anatomical lesion identification and don't worry as much about the use or need for perfusion testing in order to determine whether EVT should be provided. And what are some CTP clinical pitfalls and limitations? The first to consider is stroke mimics. What are some technical CTP pitfalls? Well, the patient may move. The brain coverage is provided with a single CTP slab or a single look. We know that the contrast bolus timing and the CTP timing can vary, and with a large vessel occlusion, contrast arrival may be slowed, and the CTP scan may end before all of the contrast has moved through all of the brain tissue. We know there can be an insufficient bolus due to IV access problems or low cardiac output, which will push blood and the contrast to the brain in a delayed manner, and there are issues related to radiation exposure. What about the CTP core infarct calculations? What are some pitfalls there? We know that the traditional core infarct calculation is based on a CBF less than 30% of normal, and we know this assessment can both under or overestimate the size of the core infarct volume. And it's important then to use the aspect score to determine if a large hypodensity, which denotes the likely infarct size, is related to an acute stroke. So it's better to screen to offer EVT more often. In other words, if the CTP appears to be limiting the number of patients that are going for EVT therapy, it may be optimal simply to do anatomical vessel viewing with a CTA and an MRA as opposed to waiting and or utilizing CTP, especially if your own AI software decreases the number of patients who apparently go to or would benefit from EVT therapy because of the presence of a likely large ischemic penumbra. And what about the ischemic penumbra calculations with CTP? So there can be an overcall of penumbra commonly in the skull base, in the posterior fossa, and or in areas surrounding the orbits. We know that with limited arterial flow due to carotid stenosis or low cardiac output or AFib, there may be some errors in the calculation of the ischemic penumbra. And in those cases, it is possible to do manual CTP penumbra volume adjustments or calculations. However, this can take time and delay decision making regarding delayed thrombolytic therapy and or EVT. And what about CTP and stroke mimics? We know that seizures, hypertensive encephalopathy, hemiplegic migraines, and the Press syndrome all can cause vascular dysregulation. And we know that variants can also cause there to be changes in CT perfusion assessments. We know that hypoperfusion can be suggested or overcalled incorrectly. And you have to correlate your CTP with clinical symptoms and your vascular finding on CTA. What about posterior circulation and lacunar infarcts? We know that the benchmarks for the algorithms for understanding CTP in posterior circulation stroke are less clear. We also know that CTP is low sensitivity for lacunar infarcts, especially in the basal ganglia and thalamus. And we know that MR-DWI may be superior diagnostic modality for the posterior circulations, lacunes, and watershed infarcts. So in summary, in posterior circulation problems, if you're trying to accurately assess the size of the core infarct and the ischemic penumbra, MR-DWI testing may be a superior choice. So how do CTP and MRP compare clinically? Compared with CTP, MR perfusion is inherently less quantitative because the signal is not proportional to the concentration of contrast. In other words, there's no gadolinium contrast bolus that would allow you to come up with a numeric quantitation of the size of these infarcts and ischemic penumbra areas. And we know that MRP requires the use of echoplanar imaging, and they can have multiple artifacts with the use of this because of any blurring or misregistration or signal dropout, especially near the skull base. One last consideration, non-contrast CT versus CTP for EVT referral. What are we talking about here? In patients who are evaluated in centers that do not have CT perfusion, can you refer patients for EVT accurately and send them to a comprehensive stroke center just from the use of non-contrast CT? So, is CTP causing referral for EVT to become too restrictive? And should we use just an NCCT in order to evaluate for the need for EVT? We know that if a large core infarct is seen on CT perfusion, the patient is less likely to get EVT. And although this is likely the right way to approach patient treatment, it may be that we are restricting the number of patients who should go for EV therapy. And a large systematic review listed here does suggest that a non-contrast CT may perform equally well to CT perfusion in the optimal referral for EV therapies. And in fact, the 3-month functional outcomes and symptomatic intracerebral hemorrhage rates were comparable in patients who received EVT based on selection with simply a non-contrast CT or CT perfusion. So is it possible that the use of late EVT can be successfully determined with a non-contrast CT for those of you who work in centers where CT perfusion is not possible? So again, from a study listed here, the 3-month functional outcome and symptomatic intracerebral hemorrhage rates were comparable after EV selection based on either the non-contrast CT or CT perfusion. It looked at 5 studies, almost 4,000 patients, and it looked at the late EVT window of 6 to 24 hours. And in fact, the CTP image did have higher reperfusion likely and a lower mortality. Odds ratios listed here. What this states or suggests is that if you do use CT perfusion, you are more likely to have higher reperfusion and lower mortality when referring for EVT. However, it is still possible to refer for EVT using a non-contrast CT alone if you do not have CT perfusion available in your center. And remember, from this from this systematic review, these studies were not randomized, and it is possible that there is some bias. That is, it may be that there's higher rates of reperfusion and lower mortality related to CTP because this test was provided or given to patients who were more likely to optimally benefit or receive EVT therapy. So, is non-contrast CT or CTP superior for EVT triage? Well, again, we have a concern that CTP will restrict the amount of EV therapies if a large core infarct is seen. We know that functional outcomes and symptomatic intracerebral rates are similar, whether you use a non-contrast CT or CT perfusion. And we know that CT perfusion does provide more reperfusion therapies and lower mortality. What's the summary? Use CT perfusion when it's available and feasible and clinically relevant. Otherwise, you can identify large vessel occlusions using non-contrast CT, the NIH stroke scale being higher than 9, for example, as a marker of a more severe stroke and a more likely large vessel occlusion. And you can use the VAN assessment where patients who demonstrate both unilateral weakness and the presence of visual aphasia or neglect changes, and use this as your notion for referral for EVT. So in conclusion, what are the overall concepts regarding the use of imaging and the use of multimodal CT? We know that non-contrast CT and IV thrombolytic therapy is still key within 4.5 hours and is the standard of care. We know that CTA can quickly identify a lesion without the need of creatinine, and a large vessel occlusion can often be demonstrated reliably with a CTA. We know that CT perfusion provides treatment guidance to experts when it is available as part of the neuroimaging workflow. We know that MRA and DWI are used for semi-urgent and unusual strokes, as in young patients. We know that if we can identify which patients will benefit from endovascular therapy, that this is key, especially because endovascular therapies are still underutilized in patients who have stroke and are evaluated in the acute setting. We know that the awareness of your stroke system will allow for optimal EVT triage, even with non-contrast CT alone. And we know that the HA-ASA guidelines address AIS neuroimaging quite well. What are our conclusions about MRA and MRDWI? We know that MR does detect microhemorrhage, but this isn't necessary. A non-contrast CT alone for detecting hemorrhage is okay. We know that MRA is no better than CTA because CTA is quite good at determining the site of a lesion in the craniovascular system. We know that CTP, perfusion, MR, DWI correlate well. And we know that MR DWI perhaps is better for posterior circulation, lacunar infarct, watershed infarct, and small vessel infarcts that may present in patients with a low NIH stroke scale and low stroke severity. We know that there's probably no significant benefit to using MR to determine our MRA and MR perfusion with DWI, except with the cases that I just described above. And we do know that MR-DWI requires that the evaluation and testing be done in the subacute period, not in the acute period, unless there's the availability of MR Lite, which may be available in the acute settings of some specialized center with a 10-minute table time at an EVT-capable center. So what are our conclusions regarding expert guidance? We know that CTA and CTP provide information to experts, not the online emergency physician or other provider. We know that the clinical history and exam and the non-contrast CT with the aspect score and IV thrombolytic therapy are the key parts of acute ischemic stroke patient emergency care. We know that CTA and CTP do provide us more information to the experts regarding the importance of the time uncertainty, like with wake-up strokes, the possible use of IV thrombolytic therapy during a longer time window, such as up to 9 hours, the use of intra-arterial thrombolytic therapy using interventional techniques and EVT, and the use of EVT up to 24 hours based on the size of the core and penumbra with the ability to remove stroke thrombus mechanically. In essence, what the use of CTA and CTP or its MR partner, these provide a thoughtful discussion about what do you think, should this patient go to EVT, and might they have benefit related to the use of this 6 to 24 hour EVT approach. What do we recommend with regard to the treatment of patients with acute ischemic stroke and the use of multi-modal imaging in the acute setting? First, quickly implement a stroke plan that includes non-contrast CT that is rapid and the use of IV thrombolytic therapy for the greatest number of patients during the 4.5 hour window. Next, a CTA should be obtained with a non-contrast CT when available without a lab delay for creatinine, looking for confirmation of the presence of a large vessel occlusion, which would direct patients to endovascular therapies. Next, use CT perfusion if you're able to, if it's present and available and feasible. If you're considering increasing the number of patients who may go for endovascular therapies between 6 and 24 hours, including intra-arterial thrombolytic therapy and or clot removal. This will maximize the number of patients who receive those additional therapies, knowing that the percentage now is quite low, and we can increase or grow the number who can have good outcomes as a result of the use of these additional therapies between 6 and 24 hours. You should learn your stroke system workflow, including EMS, what happens in the emergency department, and those intravascular radiology therapies that are provided by neuroradiology experts. You should also consider MRA and the use of DWI to determine the size of the core infarct and the ischemic penumbra, especially in those who are young or who have an unusual acute ischemic stroke presentations. And lastly, it is worthwhile offline to discuss the many 1A or best recommendations by the AHA, ASA regarding the use of imaging in stroke patients. Two last things to consider. Chris Lewandowski, a colleague of mine and good friend, provided some commentary. Here's what he said regarding this whole issue of using CTA and especially CTP in determining which patients get which therapies for acute ischemic stroke. He said for sure non-contrast CT and IV thrombolysis is surely in the emergency medicine domain. He stated that the information gained on CTP about cerebral blood flow and the size of the penumbral tissue does guide treatment, but it has some limitations. He identified that there are patients with good collaterals who slowly progress from ischemic penumbra to infarct, and those who have poor collaterals who quickly progress and have less salvage because the ischemic penumbra becomes infarcted tissue quickly. He did demonstrate that suggest that MR-DWI is a bit more sensitive than CT perfusion for measuring a mismatch in small strokes and posterior strokes and should be used in these unusual presentations. And he talked about the issue of using DWI and flare because it helps to time the stroke patient as having an early stroke, in which case IV thrombolytic therapy may still be useful. Dr. Lewandowski also referred me to the ENDOLO study, which is looking at the utility of endovascular therapies for patients who have a low NIH stroke scale less than 5 and who may or may not have a demonstrated LVO. He stated that there's no significant data regarding MR microhemorrhage determination, therefore a non-contrast CT is okay. He said there are low Tesla portable MR machines that could provide DWI and flare information, which could improve our ability to determine the need for EVT therapies in the ED. He said on CTP, there are noted now He noted that on CTP, there are noted gradations of how much hypoperfusion there is in the ischemic penumbra, and this may help in determining which of these patients with a large ischemic penumbra should go for EVT. And he stated that the volume of the core infarct does influence the utility of EVT using about a 70 cc cutoff. Those with larger core infarcts probably will not benefit from these therapies acutely and or at 3 months. And the last commentary comes from Andy Asimos, who has been working in North Carolina extensively looking at the use of this multimodal CT testing in patients with acute ischemic stroke. He said CTP does provide benefit, and he says he reads dozens of these tests a day. He stated that a negative CTP does not necessarily mean the patient is not having a stroke. He does understand that some patients with stroke mimics will receive thrombolytic therapy, but that it happens less frequently if you do CTP or DWI imaging. He noted that MR-DWI, as with Dr. Lewandowski, is more sensitive than CTP for small posterior strokes and if a mimic is suspected, and so should be utilized in those cases. And again, he echoed that the MR-DWI flare situation can identify the stroke patient as having an early stroke, therefore IV thrombolytic therapy may be of benefit. He did recognize that most MRAs are done without gadolinium. There's no contrast needed to measure the flow. He said in the future, CTP AI applications will tie a clinical prediction score to the actual CTP data, generating a stroke probability score and the potential for benefit by using extended EVT therapies. But he said generally this kind of technology where you could predict prospectively is not yet ready for prime time, and that neuroimaging workflow is not in the emergency department scope of practice. But he states that if this information is understood by emergency medicine providers, and that by hearing this information, such as the use of the aspect score and the general idea of what is trying to be done, that it is possible for the emergency care provider to aggressively move to get patients who may benefit from EVT to that therapy or transfer to a comprehensive stroke center for that therapy. Thank you for your time in learning more about optimizing the care of patients who present to the emergency department with acute ischemic stroke. You can scan this QR code to find out more about our social media links, and you can send me a question to fern.org@gmail.com or edsloanmd@gmail.com. Once again, thank you for your participation in this Fern educational effort. Have a good day.